So we are Thank you. So we are having more colleagues joining us. It is an international webinar. A quick apology for the confusion of the time in terms of UTC and GMT. Hopefully we're all here, and we will be on YouTube. It will be recorded, which reminds me, we are being recorded and the video will be published on YouTube. I will start with a quick thank you and welcome. So thank you for taking the time out of your busy schedules to come join us. We've been looking forward to it. The last few webinars have been so interesting. The people who are presenting today are from all over the world, very interesting, different diverse healthcare research. We have researchers and practitioners, and they will be nominated or put in for the Richard Cook Prize. Now, we also have a new edition, it's a new edition. We're trying to be more organized and streamlined. And what we have done is we're going to send all our attendees a link to a survey once the webinar is complete. And the link will essentially give you a certificate of participation. However, we're going to add a bit of excitement. You will all have to answer a question which is based on each of the presenters' presentation. Now, this question is going to be based on the content, and the answer will also physically be in the slides. So please pay attention. I will introduce myself. I will introduce my wonderful colleague Hamid, who will be assisting me and has helped me so much throughout the process. So I'm Sadia Wesley. I'm a lecturer of Healthcare Human Factors and Ergonomics at Loughborough University. I'm also a clinician by background. I'm an operating department practitioner, so I've worked in orthopedic theatres. Plastics is currently my favourite, and I also have worked in the emergency department and mental health trusts. I absolutely believe that human factors in healthcare is imperative for organisations like the NHS to move forward. And this is why we need people like our wonderful presenters and attendees to share their wonderful work. So I will now hand over to my colleague Hamid just to introduce himself before we start. Thank you.
Thank you so much, Sadia. Hello, everyone. My name is Hamid Morasi, and I'm an assistant professor and research associate at Kern Center for the Science of Healthcare Delivery at Mayo Clinic, Rochester, Minnesota, in the United States. And our work mostly focuses on ergonomics in the operating room. We call it surgical ergonomics, and we are trying to help surgeons with the problems that they are facing during the operations. I want to welcome you all and our great presenters today. And thank you so much. Thanks, Sadia.
Thank you very much. So we're just going to dive straight in. Very excited to introduce our next, our first presenter, Omer. I hope I've said your name correctly. I'm learning. Who will present his great work on incident commander decision making. I'll let you take the stage, Omer.
Thank you very much. Just let me know if
I am so sorry. So sorry. Questions and answers.
You can see the presentation. Everything is okay?
Everything is perfect. Thank you. And sorry for interrupting. So if you have any questions, Omer will be presenting for 15 minutes. We will have 5 minutes allocated for this presentation, and you can verbally ask the questions by raising your hands and we will unmute you. If not, you can use the question and answer option at the bottom of your screen, and Hamid will be monitoring that. So yes, I'll try not to interrupt now, Omer. All the best.
So I will present my study, Mass Casualty Incident Commander Decision Making, quantitative evaluation of instantaneous and considered decisions. So a little bit about myself. It's a short slide. So I'm at the end of my PhD, at the end of the PhD at Ben Gurion University. Basically, my research domain is the combination of human factors, decision-making and training models, and the combination of artificial intelligence algorithms. I think that the combination between the two is very important because we know that humans are limited, for example, in working memory, and where people meet their limitations, we can use algorithms. I also am industrial and management engineer in my previous studies, and also a faculty member at the FECA College of Engineering. And this is my beautiful son and wife, and I love cooking, and these are my guitars at home. Just a little slide about me. So about this study. This study is a collaboration of Ben-Gurion University and Magen David Adom, which is the Emergency Medical Service of Israel. Dr. Eli Yaffe is our POC at Magen David Adom, and my PhD advisor are Professor Avishai Goldberg and Professor Yuval Bitan. And a little bit of introduction about this research. So basically, a mass casualty incident is an emergency incident in which the number of casualties exceed the available medical resources, and it's create a management problem. And there are a lot of challenges of managing a mass casualty incident by incident commanders, and we can view the three phases of the management of the response to an MCI. First is the evaluation and triage, and the challenge in this phase is lack of information. The incident commanders arrive to the site, it doesn't know how many casualties there are and what is the situation, and it needs to start to operate. As the situation evolves from the first phase, which is the evaluation and triage, to the second phase, treatment and preparedness for evacuation, the IC copes with excessive amounts of information, and it works under limited medical resources with a lot of casualties. And when we are moving from the second phase to the third phase, which is the evacuation according to the casualties priority, the incident commanders is required to prioritize casualties for treatment and evacuation. And our objective in this study is to create a new decision-making model based on the dual process model, and to gain new insight regarding the IC decision-making process. Now, a little bit about our literature and where we come and when we involved in where we are in this all the literature. So basically there is the mass casualty incident literature, the goals, the response, the team leader roles, and the challenges. We also look about the basic human factors definitions through working memory, long-term memory, cognitive workload. We work with decision-making models, Weekend's information processing model of decision-making, Mika Ensley situational awareness theory, the RPD of Gary Klein. We do also work with mass casualty incident and disasters mathematical formulation. I will talk about it at the end and where we are using it. And the last one is about the MCI simulation, about the training, the courses, the simulation, virtual reality, and gaming environments. And when we combine basically all these worlds together, the current literature gaps that we are trying to solve is that from my perspective, a lot of the decision-making models and training models are based on qualitative subjective participants' point of view and not quantitative models. And this creates a little bit of a challenge because we don't get an objective point of view about how incident commander operates in these situations. So this study goal was to model the decision-making process of the IC according to the dual process model. A little bit about the dual process model of Kahneman. So the dual process model is basically divided into two systems, system 1 and system 2. Kahneman describes system 1 as effortless, automatic, and experience-based. And in research and in laboratory studies, we can see that responses of system 1 occurs within approximately 2 to 3 seconds. And in contrast, system 2 is analytic, is non-automatic, and is very time-consuming. So our goal was to examine the conditions under which incident commanders utilize system 1 and system 2. And in specific, we wanted to explore the condition under which novice and expert paramedics use system 1 and system 2. A little bit about our methods, about our phases of work. So we have 5 phases of work that starts with the data collection. I think that approximately 6 to 7 years we are doing data collection from MCI simulation. After we gather the data, we generated a data pipeline to manage this amount of data. And then we tag the data as interactions. In the next slide, I will explain what is this definition. And then we tag the interaction as queues and responses. And we divided it to subcategories because we wanted to understand where a queue arrived and that yielded action. And we will see in a moment the subcategories. And after that, we created a visualization and statistical analysis. So the first definition, the MCI simulation data. So we managed to gather 8 simulations of MCIs with paramedic students that are novice. Basically, it's at the end of a paramedic training program that lasts for 3 years. And it concludes with a simulation with approximately 20 to 30 casualties. And the expert incident commander simulation include experienced incident commander with approximately 40 to 50 casualties. And we managed to record 1 simulation of experienced incident commander. Regarding the definition, so the first definition is the interaction definition. And we defined an interaction as information exchange between 2 or more persons without an interruption. Now, there are 3 main points regarding this definition. And the first one is that we assume that when people talk with each other, they have the same level of information. And the incident commander can speak with more than 1 person at a time. So this is the point about the 2 or more persons. And without an interruption, this is a critical point because this is the incident commander situation involves a lot of information. And when the incident commander talks with one of his EMS members and another one joins the cells and is saying, we found more casualties. So it brings a new information to the interaction. And then we divide it to a new interaction because the level of information just changed. After that, we tagged each interaction as queue, which basically cues can be verbal, visual, or auditory. We focused on the verbal cues. And the second one, it's an action. Action is an order given by the incident commander. Now we divided the cues and actions into 2 subcategories. Cues are defined as the first one, cues with the following response. Cues with the following response is a situation where the incident commander and when someone gives an information to the incident commander and the incident commander responds with an order what to do. And there is the second type of queue without a response. And queue without a response is the same situation when someone is giving the incident commander new information, but the incident commander doesn't respond or doesn't give any order about what to do. And I will talk about it at the end. We are doing a research about this topic right now. The second subcategories are actions. Now, actions are divided to response following a queue, as I mentioned before, situation where the commander got new information and then gave orders what to do. The second one is an action without a queue or an initiated action. And this is, for example, situation where the commander decides, for example, to reorder the casualties prioritization for evacuation without any preliminary queue. So the main issue here that there is no preliminary queue and the incident commander decided what to do. The last one is action following the MCI protocol. So basically, paramedics have protocols for basically for the first phase of the mass casualty incident, and action following protocol is defined by an action that the commander initiated, but it's in the protocol. So this is the difference between action without the queue and action following the MCI protocols. Regarding the results, so in this graph, we can see this graph describes the novice incident commanders, and we had 8 simulation. So we had to normalize the timeline of each simulation, and we normalized it to 10 time frames. So we can see it at the x-axis, and this is the horizontal line, and the vertical line represents the average percentage of action queues and all the subcategories. Just 2 more things. The first vertical line represents the transition from the first phase to the second phase, and the right vertical line represents the transition from the second phase to the third phase. Now, regarding the results, we can see in the blue the queues that the incident commander received, and these are the actions. Now, the interesting things is that the green bars represent the protocol-initiated actions, and we can see that the novice incident commanders at the first phase used the protocol, and when we move to the second phase, the blue line represents responses to queues, and we can see that the responses to queues maintain a constant trend throughout the simulation. And the last bar, the brown bars, represent the initiated actions. Now, this is the interesting part. We can see that even novice incident commander has some ability to initiate actions during MCI simulation, and I will explain our assumptions for why this is possible. This is something that we didn't know in the literature about the ability of novice incident commander to create initiated actions. So this is a new insight. If we are looking at from a p-value perspective, the left box plot represent the differences between the protocol initiated actions throughout the phases. So we can see that there is a significant difference between the amount of protocol-initiated actions from the first phase to the second phase and from the first phase to the third phase. There is no significant difference between responses to queues. This is the middle box plot, and on the right we managed to see a significant difference between the number of initiated actions in the first phase to the third phase and to the second phase to the third phase. And this is what's really this is the new insight that we managed to find at this study. When we look about expert decision making, and this is a completely yes.
Sorry, you have 2 minutes left.
Okay, so this is a completely different graph. We can see that the amount of queues is really low, but the amount of actions is really, really high. And the interesting thing is that the expert decision making mostly initiate actions, in contrast to the novice decision making that mainly responds to queues. So if I'm going to a little bit of discussion and future directions, basically to conclude it, I will move to the next slide. Novice decision makers basically use only system one. They start with the protocol initiated actions and then response to queues. where expert decision-making start with system 1 and then move to system 2 to initiate actions. And so this is the difference between novice and experts. And there is another regarding queues without responses. We are using now the working memory theory to understand why novice decision-making have queues without responses. Maybe in the next webinar I can present it. And the last thing about the current and future work. So basically now we are, after we managed to create a lot of theoretical models and publish them, we are just finished to create a framework for mass casualties incident decision-making training simulation. And on the right, you can see the simulator. We are doing a user testing right now to try to improve the incident commanders training. And another topic that I'm working on is an optimization problem, and to try to allocate medical units to disaster site and task scheduling within each site. It's a different problem, but in the same domain. And that's basically it. Thank you for listening.
Oh, I'm just seeing if my camera is on. Oh, no, it's not. Sorry about this. Hi again. Thank you so much, Omer. That was absolutely amazing. I'm having a quick look at the Q&A. I don't think we have any questions. However, I will give our attendees the opportunity to ask any questions. Omer, thank you for presenting that work. I do have a question because I find emergency responses absolutely fascinating. So does anybody have any questions so that we can unmute you? You could switch off your camera, as in show us you and raise your hand, or raise your hand virtually. Okay.
I have a question.
Oh, lovely. Thank you, Sharifa.
Omer, I'm curious about the findings, whether the team expected the results, sort of the differences between the novice and the expert, and if so, or was it like shocking or surprising, and if so, why?
I don't think it was shocking or surprising, but I do think that we had some expectancy that the expert decision maker will initiate more actions. We didn't thought that the differences will be so high. We didn't thought that there was such in theoretical perspective that novice decision maker will use only system 1, where expert will start with system 1 used and will move to system 2. We're basically expected that expert decision making will utilize both system 1 and system 2 after they finished with the protocol. So this was a little bit surprising. We do need to remember that this is one simulation. We have a difficult time to collecting data of expert decision makers. There are not many simulations that are going on.
Cool, thank you.
Excellent. Any other questions? Oh, okay. So Hamid, like I said, I really do find this work very interesting. So like I said, I worked in A&E research for about 8 years, and my PhD is based on human factors and emergency responses. And what I found in my research, and what I still find, because I'm so theory and method orientated, is that we don't get into the nitty-gritty of what people are actually thinking. So when I worked in research, I used to work on weekends, and everything was so easy. I could do cannulation, catheterization without thinking about it. But the minute I have to write something, even an email, I have to think. And then I've just realized now it's system 1 and system 2 thinking, and it's made so much sense. So thank you for this enlightenment. What I want to know is, I know you've given the future directions, and I appreciate that, is can this work be applied in different specialities? So, for example, in the NHS, we have stroke teams. So people, when they have a fast positive and they come into research, we have neonatal teams, we have, diabetes nurses. Do you think we can apply these findings to specific cases, emergency cases?
So yes, we are currently starting to think about working in the in-hospital setting at the emergency department, especially to prevent the surge capacity effect of mass casualty incident, where there are a lot of casualties that are arriving. We do think that we can take this platform, this theoretical thinking, and just move it to another setting. There will be some adjustment required because the pre-hospital setting is very chaotic and the in-hospital setting is more, they have more time to be prepared to these incidents from the moment it occurred. So yes, we are looking at it right now, and at the paper that we published at Applied Ergonomics, we also suggested to take this work to the in-hospital settings, and we think that with the correct adjustment, it will work.
I absolutely agree. And if you do want to do any work in England, just get in touch.
Sure.
Thank you very much. Now, if you could, what we're going to do now is move on to our wonderful next presenter, Sharifa. It is you. Hopefully we will have Sharon joining us. She is here. So we're not losing out. We're just sorting out some technical difficulties. But Sharifa, the stage is yours. Oh, sorry, Sharifa, if you could, if you could kindly introduce yourself. And once you've introduced yourself, Hamid and I will then start your 15-minute timer from your first slide. Or is it introductory?
Yes, after you introduce yourself, the time will start.
Perfect.
Amazing. Thank you, Saida and Hamid, everyone. Good morning, good afternoon. Thank you for joining today's webinar. My name is Sharifa Omar, and I'll be talking about empirically derived user attributes and personas for COPD telehealth design. So a little bit of background, I'm a senior human factors engineer, or also called consultant, specializing in the healthcare and medical device development. I help basically pharma companies design and develop medical products that are safe, effective, and usable for the end user. I completed my master's degree in translational health sciences from Oxford last year. And the presentations today is my master's research thesis, where I collaborated with the team in Oxford. And I'm really excited to be sharing the key findings and learnings from my research today. So that goes my introduction. So before we dive into the technical aspects of my research, I'd like to invite everyone here to take a moment, take a deep breath. Think about the last time you were consciously aware of your breathing. For most of us, breathing is an automatic function, something that we do without thought effortlessly. But not everyone shares this experience. Now, let me tell you about George, a participant in our study. For him, something as simple as climbing a flight of stairs triggers a wave of panic, but not because of the physical effort to do so, but because of the fear of not being able to breathe. And he described it vividly. He says it's quite scary, really, because it does, like if I know I've got a lot of stairs to go up, I start to panic because I know I'm going to get out of breath. And I really do get out of breath. I gasped for it. I couldn't think of anything else. My mind was overactive. It was really scary. And when you are feeling like that and you are really scared and there's nobody there, that is really scary. I wanted to do a British English accent, but I don't have that, unfortunately. But like this patient story, George, there are countless others often buried among runs of data collected during research. So these stories, rich with intricate details of lived experiences, frequently do not make it to the forefront of product development discussions. And I've seen this everywhere in my research with them at Oxford, but also in countless times that I'm consulting companies with product design. And they are overshadowed basically by more quantitative data or lost in organizational shifts and transitions. So today I'm excited to share findings from this master research thesis, which was driven really by a desire to capture the complexities and intricacies of experiences like George's, and to transform them into actionable insights that can inform and enhance product development for telehealth solutions for COPD patients. So we'll come back to George's story later, but because it is a powerful example of why the work that we're discussing today is crucial. So a little bit of background information on COPD and telehealth. So COPD, or chronic obstructive pulmonary disease, is a major global health issue, significantly impairs respiratory functions, leading to symptoms such as breathlessness, fatigue, and frequent respiratory infections. It is the third leading cause of death worldwide, poses significant burden on both patients and healthcare system everywhere. In response to the growing need for accessible and continuous healthcare for chronic conditions like COPD, telehealth has emerged as a crucial technology. And COVID, as we all know, accelerated this too. And telehealth allows for the remote delivery of healthcare services and clinical information, really especially vital for COPD patients, because consistent monitoring and removing the need for patients to frequently visit the hospital really greatly impact the patient's quality of life and disease progression. So now that we've covered the background on telehealth and COPD, let me introduce you to the EDGE program. It's officially known as the Self-Management and Support Program. It is an innovative initiative based off Oxford. It focuses on the development and testing of a telehealth system for COPD patients. And it provides patients, basically, patient get a tablet with an app to read the patient data. Patient get a pulse oximeter and a wrist run step count. And they're asked to use this tablet to provide the details about their clinical condition, i.e. their COPD symptoms, as desired once they receive the system. And then a clinical research team basically monitor the data collected by this tablet at a regular weekly interval to ensure that, one, data was logged as expected, and number two, to track any alerts or signals, allowing the clinical team to react appropriately. And this self-monitoring support also aims to improve medication compliance and enhances psychological well-being so that it integrates seamlessly with the care provided with the clinical teams at the Oxford University Hospital. At the time this research was conducted, EDGE was offered to a select number of patients in the area as part of a clinical research efforts. So this allows the program to gather rich, both quantitative and qualitative data from a diverse user base. So during my time at the University of Oxford, I had the opportunity to collaborate closely with the development team of EDGE. So earlier in this collaboration, I learned that the team amassed a wealth of interview data from participants, but this was not fully leveraged. And they weren't sure how to continuously use this interview data throughout their product development. And this scenario is not uncommon in a fast-paced research development environments where this focus can swiftly shift to new projects so that subjective data such as George's experiences would just be left underutilized. And I see it too with my clients right now. It's the same problem. So recognizing the potential of this existing data, the research aimed to delve deeper into these interviews to extract nuanced understandings of the patient's daily experiences, struggles, and needs. And this was just not about analyzing the text, but it's really about bringing these voices of those living with COPD into light and ensuring these voices actually lead the way in shaping effective telehealth solutions. So that summarized the what, basically, which is, I'm trying to answer how to effectively capture COPD patients' complex experiences to inform and improve telehealth design. And why? So a couple of reasons. One, I wanted to unpack persona development. User personas is widely used in our space as a tool to represent various user types for whom a product or service is designed. And my first introduction was to user personas was at Farm Design, the first firm that I worked at, where the tool was so integral to product development process. While it is an invaluable tool, it also faced criticism for oversimplifying complex human behaviors. And so I wanted to challenge that, and I wanted to critically examine and enhance persona development methodologies to address this common criticism, aiming to create personas that truly embody the varied and intricate experiences of COPD patients. Number two, knowing how difficult it is to obtain real-world patient data, I was driven to really use the data that we have. And by tapping into the data that we already collected, we can make sure that these key insights are preserved and continuously used in product development. And number three, I wanted to provide the development team with something with a user attributes or characteristic and persona so that they could design more effective telehealth solution tailored to the needs of COPD patients. So I covered the why, so let's get into the how. So subjective data, as I already mentioned, was already collected as part of EDGE trial. So these involve conducting semi-structured interviews with either patients or both patients and caregiver to gather insights into their experiences with COPD and their interaction with the EDGE platform pre and post clinical trial. So the study itself was conducted in 2 different segments, and they had over 45 patients. But for the purpose of my research, a total of 15 participants' data were purposely sampled for this master's research. And the study employed secondary qualitative data analysis of the patient interviews. The analytical framework was heavily inspired by the work of Burrows et al. In their paper titled Empirically Derived User Attributes for the Design of Home Healthcare Technologies. And that paper really provided a robust foundation for interpreting the complex data that we collected. So then we perform longitudinal analytics method to create case narrative summary for each participant data that allowed us to track changes and consistency in patient experiences over time. And then subsequently, thematic analysis was performed to extract emerging themes within each patient narrative. So this was instrumental in empirically deriving the patient's attributes or characteristics. And from this thematic analysis, 16 distinct patient attributes emerged. And these attributes were then used to create 4 detailed personas representing the diverse experiences and needs of COPD patients. So the thematic analysis revealed 16 attributes across 5 socio-technical themes, including life and social context, experiences of illness and COPD condition, self-management of health, interaction with care system and technology, and experiences of EDGE. I'm not going to go into all of them, but for example, in the life and social context theme, we explored how patients' attitude toward life and the support system available to them really affect their integration of telehealth solutions. So, and each team that we have here provided a nuanced view of the different aspects influencing COPD and management. And these are all essential for designing user-centric telehealth platform that's not only safe and effective, but also actually being used and adopted by users. So to give you a little bit more example of, and these are the 16 attributes across 5 socio-technical teams. Just going to leave it for 5 seconds. But to give you a little bit of example of how the thematic analysis was conducted and how it informed our findings, these are the excerpt interview data from patient HAA60. So first we start with raw interview excerpts that highlight key patient concerns or experiences. And then each excerpt is coded for recurring themes such as anxiety due to breathlessness or reliance on telehealth monitoring. These codes are then grouped into broader themes, which help to illustrate the overarching patient experiences and challenges. And we came up with that 5 themes that I showed you before. And from these themes, we derive attribute or characteristics that are critical for persona development, ensuring that the personas are not only representative, but also grounded in real patient experiences. Next, practical application of the user attributes. For example, there's a lot of other uses for the user attributes, but one that we find would really help the development team at the stage was the persona development. So to transform the findings into practical design insights, we use the attributes to develop user personas, which involve mapping the attributes on a continuum, ranging from negative to positive value, so that we can visualize the diversity in patient experiences. We then place participants along this continuum based on their interview responses, which help us identify patterns and group similar attributes. And this allowed us to create detailed personas. And we were able to find about 4 distinct user personas in the data. So we have persona of George Fletcher, a 70-year-old retired landscaper. We have Andrew, Liz, and Daniel. And these personas can now be used for each team and any telehealth really developers throughout the product development to ensure that their needs are captured within the design. So let's get into the conclusion, key takeaways. I think the research underscores really the critical role of understanding the lived experiences of COPD patients in designing effective telehealth systems. And the detailed personas developed from this study are really vital tools for designing interventions that are not only technically feasible, but also deeply empathetic to the user's need. I'd like to highlight 3 key takeaways from the presentation. Number 1, always try to use and leverage existing interview data. I invite people to really look at the data that you have, because development team often face product shift, reorganization, and this, again, like I said, leading to loss of valuable insights. Number 2, to create empirically derived personas that capture complex lived experiences of patients and not just create personas from thin air, which I know some, if you look in the websites, they don't always show you how to do it. And really, these personas are really allow us to approach product development with deep understanding of our users, ensuring that the solutions we create are tailored to real-world contexts and needs. And finally, to optimize product development process through socio-technical consideration. Understanding that just technology is not enough. We need to consider human, social, and organizational factors as equally crucial to technical factors to create safe and usable product that can be effectively adopted and integrated into patient care. So as a human factors practitioner myself, with really experiences championing usability and safety in the design of medical devices, when I was doing this research, it really served as a reminder to me and hopefully to other practitioners that while usability or human can be a key agent of innovation diffusion, it by itself is not enough to ensure effective and sustainable adoption of telehealth solutions. So providing patients like with a usable tablet computer, it's not sufficient. We need more than that. Other practical, clinical, social needs that needs to be considered. So these key takeaways underscore my belief that social technical lens is essential for informing telehealth design. It is a message that hopefully we as human factors practitioner continuously to emphasize that integration of technical solution within human context is vital for sustainable implementation of innovation. So with that, that's all I have. Thank you so much for your attention. I'm sorry if I'm going too fast. The 15 minutes really. So I'm ready to answer any questions that you may have and look forward to engaging to discussion.
Amazing. Sharifa, that was a wonderful presentation. Very, very important work. Thank you. And really nicely delivered. Yeah, I think you need to work on that British accent, but we all start somewhere. No, thank you very much. I don't think we have any questions in the question and answer or chat.
Sadia, I'm checking the Q&A and also the chat. So please send your questions in the question and answer or in the chat, but there is no question right now. Sharifa, it was a great presentation, and I didn't let you know when it was like 2 minutes because you were on your last slide. So I just thought you will finish on time. That you did.
Amazing. Can I ask a question?
Yep.
May I ask a question, in fact? Okay, so I really like the qualitative component of this study. Great work. COPD is very important work. Of course, all of healthcare is. So with these personas, am I correct in understanding that you did the thematic analysis and the themes have fed into the development of these personas?
Yes.
Perfect. That's amazing. Okay. Which leads me to this. Will these personas be updated? Like you've stated the importance of other factors like life experience, which is really important. So just say, God forbid, we have another pandemic. Like, would that impact how these personas are used?
I think personas, like any other tools, especially in human factors, should be a living document. You know, for example, user need document is a living document throughout product development. We always have to come back to it. We refer to it as, you know, this is the things that we need to do, but consistent effort in managing and keeping it alive is really key. I know from the use of user personas in my experiences, usually when we are already fixed, especially with this amount of research and data, we could safely say that maybe not a lot of changes are expected. But I think it's always good to always reflect, go back to the research that we did and reflect back if, you know, if there are any changes, any more data that we collect, if it's still aligned with what we already collected and suggest.
Amazing. Thank you for answering that question. Right, so we have our final presenter, Sharon. Sharon, if you could kindly switch on your camera. So as we are all aware, we have 15 minutes of the presentation. Alexandra, our wonderful magician behind the scenes, is going to assist us in this. Thank you. God, I feel like I'm using AI with my fingers, but I'm not. I think if Sharon can just say next, I think next is a good word, when you want to move slides. And yeah, the stage again is yours. Like I said, quick introduction. And yeah, excited to listen to your work.
Thank you, Sadia. Can you hear me?
Yes, we can.
Okay. Hello, everybody. My name is Sharon Beza. I'm a human factors practitioner, and I work for Shrewsbury and Telford NHS Trust in the United Kingdom. I work within their patient safety team. And today I would like to share my experiences on designing a user-centered policy and procedure for nasogastric feeding tube insertion in the adult patient. Next slide, please. So nasogastric tube feeding is when a narrow feeding tube is placed through the nose and down into the stomach for the purpose of delivering fluid, nutrition, or medication directly into the stomach. A misplaced nasogastric tube can result in fluid, feed, or medication being delivered to the lungs. And this can have dire consequences for the patient. It can even result in death. So following review of some patient safety incidents related to the use of nasogastric tubes, we made a decision in our trust to review our local policy on insertion of the feeding nasogastric tubes in adult patients. Next slide, please. The aims of the work were to align our local policy with national guidelines, to mitigate risk to our patients, that is generally to improve patient safety, and to improve usability for our staff. Next slide, please. So the Chartered of Institution of Human Factors and Ergonomics has published guidance on the design of effective work procedures. This guidance encourages involving those who do the everyday work and understanding work is done to inform the review or design of work procedures and processes. And we decided to follow that guidance when we were reviewing our policy and our procedure. So we set up a working group which consisted of subject matter experts. So they were high-level clinicians and also members of the patient safety team. And this group initially reviewed national guidelines, policies from other organizations, and published literature to determine what work as imagined or work as prescribed is. This then was followed by doing a hierarchical task analysis, which we then used to map out the process for the NG tube insertion. After this, we did failure modes effects analysis, and that was to identify potential hazards in the process that we had created. And we also used a risk priority matrix to gauge and prioritize risk. Following that, we wanted to look at work as done, to understand it and to capture it. So we did observations and interviews or informal discussions with various groups of relevant staff. These were doctors, nurses, dietitians, speech and language therapists, amongst others. And from all of that work, we then created a flowchart of the process for the insertion of NG tubes. And then we took iterations of this flowchart and carried out usability assessments through simulation sessions with mannequins and through user feedback sessions with various staff groups. So the groups that we had used before and some additional ones like our critical care outreach teams. Next slide, please. So from this work, some of our key findings, particularly from the interviews and observations, were things like problems around clarity of information on confirming the position of the NG tube. So you want to confirm whether it's in the stomach. So there are some confusions around that. There are also problems around documentation of information, problems with staff skills and training, and issues around service provision outside of hours. So like in the evenings and late evenings and on the weekends. And we also identified problems with access to the policy and access to equipment that is required for the NG tube insertions. I'd like to discuss in the access to to equipment in a bit more detail. I won't discuss the other findings. So with regards to access to the equipment, we have specialist teams. These are people who are not based on the wards, but who perform a substantial number of NG tube insertions for the wards. For example, the hospital at night team or the critical care outreach team. They were experiencing difficulty accessing the NG tube insertion equipment. And this was because the equipment is stored in different places in different wards. So what I mean is, for example, on some wards, the equipment for the NG tube insertions was stored in the storage cupboards alongside other equipment that is used on the wards. But on some of the other wards or clinical areas, it would be stored in the kitchens alongside the feeds for the patients. There was also an issue that to access the storage cupboards, you needed codes for the doors. And these codes were also different on all the different wards. Therefore, if one of these staff that was coming from outside the ward needed to access the storage cupboard, they had to find somebody who knew the code, which would be maybe a member of staff who was employed by the trust and based on that ward. On some days, you might go into the ward and actually find that the majority of the staff working on that ward are agency staff. And sometimes they didn't know the codes for the doors. So you can imagine the amount of time that would be wasted trying to locate a person who knows the code and then accessing the cupboards. So our intervention to address this problem is that we've now made it that all equipment is now stored within storage areas. The equipment that's needed for the NG tube insertions, nothing is stored in the kitchens anymore. We also created a list of all the equipment that's required for the process for the NG tube insertions so that a person can quickly assemble what they need to carry out the procedure. Our next steps with regards to this is around reviewing the issue of the door codes. We still to address that. Next slide, please. So now I would just like to share with you what I can describe as key learning points for myself from this work. My reflections. So the first reflection is about engagement and support of the relevant people. This is in two parts. So for the first part is around engaging the support of the correct level of leadership or authority to enable the work that one wants to carry out. And the second part is around engaging or consulting all the relevant stakeholders. So with regards to getting the right level of leadership or support, at the onset of the project, we got support from our executive leadership. Basically, this made a difference because it enabled us to have access to resources. And mainly, it's the human resources. So if you have experience working in healthcare, you know how difficult it is to get clinicians to come off from their normal daily clinical roles to attend meetings. So, but because we had the right support and the right backing, we were able to set up the working group and get high profile clinicians to attend the working group. But also it meant that we were able to get other levels of clinicians within the organization to attend and participate in the focus group and the simulation sessions that we had. Just to say that not every project obviously will require support from the executive, but my point really is about knowing what the right level of support or leadership you need for the work to facilitate the work that you want to do and to effect the changes that you want to make. With regards to engaging those that do everyday work, my learning point was around ensuring that we've involved all the relevant parties. This might be involving people in different ways or at different stages of the work. The importance of this is that to avoid having to make changes to the work that you've done at an advanced stage because people with significant or relevant contributions were not involved at an earlier stage. So I know sometimes it might be difficult to know exactly who all the stakeholders are, but I think it's useful to create an initial list of stakeholders and then consult with those to find out who the additional people that need to be engaged in the work are. My next learning point was around addressing other influential systems issues that exist, pre-existing issues. So what I mean here is you can design a great user-centered policy or procedure, but if there's not the right infrastructure to support its use, then it might actually not really achieve what you want to do, or it might not really be any good to everyone. So it's really looking at the system and identifying where there are pre-existing problems and addressing those. So if, for example, as part of the work, we liaised with our IT department to address some glitches that we'd identified in the IT system. So without addressing these problems, our users would have difficulty accessing the policy on our internet. So um, in practice, what that worked out really is before we addressed the glitches, if you enter the keywords, you ended up with several pages of documents. But since we've addressed this problem now, when you enter those keywords, you end up with 4 documents only, and one of which is the policy that we need. So that's a big difference. It's easier for users to be able to access the document. The other, one of the other system issues that we addressed is the equipment one that I've already discussed. Next slide, please. So the next learning point was around optimizing dissemination of the policy or procedure. What I mean is that we had to ensure that all the relevant users had access to the policy and procedure. So we thought the best way to do that would be to consult the users on what would be the best way of sharing the policy with them. The traditional way of sharing new policies in our organization is through a bulletin that covers a broad range of organizational issues. And in that bulletin, there'll be a link to the new policies and procedures. So we explored other options of sharing the policy and procedure, and such as identifying specific or creating a specific communication highlighting this policy only. So if it was a bulletin or an email, it was just about the policy and not anything else. So, people really got to see it. It wasn't buried somewhere within other information. We also looked at attending team briefs and huddles, and we created hard copies of the flow chart and placed these in key areas that we thought. For example, we put a hard copy in the staff room. We had hard copies in the storage areas, so that if somebody was going to do an NG tubes in session, they had a copy that they could actually look at and make use of. They didn't have to necessarily go onto the internet to look at the policy. So that made a difference as well. The last learning point for me was around awareness of related work within the organization. So the NHS has a history of silo working. So you have groups of people doing work or projects that other people do not know about, and there's no communication. So one of the lessons for me was that it's really important to be aware of other similar or related work that's going on in the organization. This is for two reasons: to avoid duplication of work that's already being done, and also so that we can be aware of any work that's going on that might be contrary to what you're doing or might have some kind of adverse impact on the work that you're working on. So, for example,
Sharon,
towards
sorry, Sharon,
hello.
you have 2 minutes left.
Okay, thank you. So towards the end of this work, for example, we discovered that there was work that was going on in another department, which also focused on the use of NG tubes, but created some confusion around the work we were doing. So we were able to collaborate with our colleagues and to address these issues, and the issue was solved and everybody was happy. So I really learned that it's important to be aware of what's going on and to collaborate with my colleagues. Next slide, please. So that's to conclude. I learned in this work that it's really important when we're designing and implementing a new policy or procedure to understand the system. So who are the people that are going to be using the policy and procedure? What are the tools? What is the environment or organizational factors that are influencing this? And to understand those interactions and where we identify system problems, to be able to address them so that they do not have a negative impact on the effectiveness of the policy and procedure we're creating. I also learned that it is important to anticipate any unintended consequences of the work that we've done. And lastly, when the work is completed, it's important to monitor and keep track of any issues that have emerged as a result of introducing the policy. That's it, really. Thank you for giving me the opportunity to share this. And that's just a list of the references that we used as part of this work. And I'll be happy to answer any questions now. Thank you.
Thank you so much, Sharon. That was excellent and extremely important work. I'm so glad you managed to share it. I can't see any questions. Hamid, are there any questions at all?
No, there is no question.
Okay,
so far. So again, please send your questions in the question and answer or the chat.
Amazing. I do apologize for running over. I've got a quick question, and so I just wanted to ask, how did you get high-profile engagement?
Well, it was a series of meetings with the right people, really. So I think the back of it was we'd had a couple of serious incidences.
Oh.
So obviously we did an investigation. And then after that, we realized that for us to be able to do something to make a meaningful change in terms of the policy, we needed to talk to the right people. So we identified key people within the organization that we needed to speak to. And then it was obviously communication by email to start off with. And then we had to attend a few meetings to get them on board. And it was really about explaining why it was so important to have their support for us to make a difference in terms of the work that we wanted to do. And I think that's how we ended up where we were. Yeah. So, yeah.
Excellent. Yeah, I just think it's so important that, you use the methods, you walk them through, and, you got to that granular detail, which is so important when it comes to carrying out procedures like this. And the fact that you actually thought about things like the accessibility, making your policy into 4 pages, and then getting the diagrams or algorithms. Amazing work. So great work, and I hope it continues.
Thank you.
Thank you so much, Sharon, and thank you, Alexandra, for helping us with that technical glitch.
Yeah. So Sadia and Sharon, we have a comment. It's not a question, but it's a comment. It says not a question, but just to say this was a great project. We have recurrent alerts saying follow the guidance for misplaced NG tubes. And this systematic review of issues and improvements that are likely to be successful is brilliant. So thank you, Sharon, for your work again.
Absolutely. And I think we echo that comment, Sharon. It's very important work. And I'll just be like, I'll be checking out what you're doing at the Trust, because like I said, it's great to share and learn. I won't keep you all for long. I just want to say a very, very important thank you to our wonderful presenters, Omar, Sharifa, and Sharon. Thank you for putting up with our emails and responding. Really appreciate it. You've showcased some excellent work, and we'd love to the IEA would love to continue to learn what you're doing. So thank you for your contributions. Hamid, as always, you have been amazing. Thank you, Alexandra, and thank you very much. We will call that an end. Yeah, thank you.
Thank you.